My name is Mark Bowron, and I'm here to talk about my project, Cognitive and Motor Outcomes Predicted from Lesion Location and Lesion Network Mapping. So stroke is a leading cause of disability worldwide and in the US in particular. After a stroke, patients can experience a wide range of symptoms, including, as many of us know, things like aphasia and visuospatial deficits. Some of these problems will improve after the stroke, but some of them are going to persist and become permanent disabilities for patients. So clinicians and scientists alike have long sought to predict long-term outcomes after stroke in order to improve acute and subacute rehabilitation strategies and treatment planning, and also to improve the design of clinical trials. The ability to predict future problems after a stroke quickly and accurately is really important because we know that the plasticity after a stroke is greatest pretty soon after the stroke actually occurs. So we want to maximize the gains that we can get out of this time period with accurate predictions. So lesion location is one of the best predictors that we have. There's a long clinical and experimental literature about how lesion location is associated with different neuropsychological outcomes, and it's much of what neuropsychology is based on. Because structural neuroimaging is routinely collected after stroke, I think we have an opportunity to integrate the basic and applied literatures in this realm and really bring that to bear on patient care. In particular, I'm thinking of research tools here like lesion behavior mapping, which is sometimes called lesion symptom mapping. Lesion behavior mapping is just a tool that allows us to associate a lesion location, like the inferior frontal gyrus, with an outcome like aphasia or expressive language problems. Similarly, lesion network mapping is a tool that allows us to link a problem after a stroke to the remote network effects of the lesion. So just because we have a lesion in the Broca's area doesn't mean that's the only area that's dysfunctional. There's a whole network that might be affected by these strokes. And unfortunately, the literature up to this point has not actually evaluated these tools like lesion behavior mapping and lesion network mapping for predicting cognitive and behavioral outcomes after stroke. We tried to address this gap in the literature by taking a multi-cohort approach. In the first set of analyses, we used data from the University of Iowa, which contains a neurological patient registry of patients with focal brain lesions, as well as data from the NEACH clinical trial, which contains data from patients with stroke. We used MRI scans and neuropsychological testing scores to create lesion behavior maps in a common template space that are just three-dimensional maps of the areas of the brain that are associated with a behavioral deficit when damaged. We then took those lesion behavior maps and found the gray and white matter peaks within them to find the networks associated with the lesion behavior map. For the gray matter peaks, we used resting state functional connectivity data from the Human Connectome project to find and generate what we call a functional lesion network map. And then we used structural or diffusion weighted imaging data from the Human Connectome project to generate what we call structural lesion network maps. So these are two different kinds of ways to represent brain networks here. We then used all of these data, the lesion behavior maps and both of the lesion network mapping techniques, to try and predict outcomes in a separate cohort of patients with stroke collected at the Washington University. So again, we traced their lesions into the same common template and found the overlap, or the lesion load, so to speak, of each patient's lesion overlaid on top of the lesion behavior map, the structural lesion network maps, and the functional lesion network maps. All of this to predict 12-month outcomes as our primary dependent variable. Just a little bit more data on the cohorts here. So in the training cohorts that generated the maps, you can see that we have data across multiple cognitive and motor domains actually here. We tried our best to match up the predicted domain in the Washington University cohort with the data available in the other two cohorts. We performed lesion behavior mapping using the R package called LesiMap. LesiMap is a multivariate lesion behavior mapping package. In the end, LesiMap produces a voxelwise map of values normalized between 1 and 0, where greater values indicate greater importance for explaining deficits in the behavior in question. Like I said before, we took these maps and generated the structural lesion network maps by submitting a peak in the white matter to the Human Connectome project dataset, and then deriving the white matter streamlines that pass through these points. We performed functional lesion network mapping in a similar manner, where we took here the gray matter peak of a lesion behavior map and submitted that to a connectivity analysis using functional resting state data in the MGH dataset of the Human Connectome project. And here you can see in red, we just have the average activity within this region over time, And then we looked at other voxels and correlated activity over time to see which regions were coactive. So for example, here in yellow, we have a voxel that would be highly correlated with the activity in this region. And here in blue, we have an activity of some other voxel that would be highly negatively correlated with the activity in this region. If you put those all together, you would have a single functional lesion network map. Because each of these lesion network mapping analyses generated multiple lesion network maps, we actually had to reduce these data to make more sense of them. And we just reduced these to, here in this case, would be two principal component maps that explain the variation across these maps in a more parsimonious way and make it easier for us to interpret these data. And now we move to the WashU cohort, which had the data we actually wanted to predict with these maps. We had data across 3 time points, less than 2 weeks after the stroke, and then 3 months and 12 months after the stroke. Because we had longitudinal data, we used a longitudinal data modeling technique called latent growth curve modeling. Latent growth curve modeling lets us model simultaneously the intercept of our data, along with the slope or how the data changes over time. And with that, we modeled, like I said, the intercept and the slope simultaneously, as well as the correlation between them. And this served as our sort of baseline model across our analyses. So any time that I talk about an effect size here, or an effect of a lesion behavior mapping lesion load variable, for example, what I mean by that is the change from this model to this model, such that in the first model, this parameter of the effect of our lesion load variable here is turned off. So that would mean that what we're comparing is a model where this effect is null to a model where this effect is actually estimated. If that estimated effect provided additional value to the fit of the model, then that would be considered a significant model change, and then we would actually evaluate the parameters from there. And now on to the results. And here's our first primary question. Does lesion behavior mapping predict post-stroke recovery trajectories? So here we have the lesion behavior mapping result on the left and the cross-cohort prediction on the right. We won't get too into the anatomy for the sake of time, but you can see here that the Boston naming test identified various left hemisphere areas as important for expressive language. And that map did a pretty good job of predicting the intercept across cohorts, more so than the slope. And here we see that the intercept was not well predicted by non-target maps, which include things like the memory maps, the motor maps. Here we see the token test result also identifies some left hemisphere regions, with a little bit more strong signal coming from posterior regions. And again, more strong intercept prediction relative to the slope and relative to the non-target predictions. We didn't actually see any really notable predictions for the memory domain here. And for the motor domain, we saw that the Fugl-Meyer test identified some descending white matter tracks and did a pretty good job of predicting the intercept in motor outcomes across cohorts. Now, does structural lesion network mapping predict post-stroke recovery trajectories? So again, the results of the structural lesion network mapping on the left and the cross-cohort predictions on the right. We can see that we have 2 components here. The first component is an overall left hemisphere white matter component with strong signal coming from the frontal region as well as the frontal parietal region. And again, and for the second PC here, we see that this is actually a map that makes a distinction between the anterior and posterior aspects of this map above. Both do a pretty good job of predicting the intercept more than the slope, just like the previous results. And we can see here from the token test, we get the first time that we actually get a stronger prediction for the slope than the intercept here. For the Ray auditory verbal learning test predictions across cohorts, we see that we actually still don't predict anything very well, although there's a higher absolute value for the prediction of the slope here than the intercept. And for the prediction of motor deficits across cohorts, we have cortical spinal tract heavy lesion network mapping results here that do a pretty good job of predicting the intercept across cohorts. And what about functional lesion network mapping? Here we can see in the Iowa cohort, the Boston naming test was associated with 5 principal components that really varied along 2 different sort of networks here. As you can see in the first PC, we have a frontotemporal parietal network. And in PC4, we see the first major shift along as we go through the list here, where we see a cingulo-opercular network pop up here. Regardless, all 5 of these maps do a better job of predicting the intercept and the slope. We see the same thing happen across cohorts for the token test, with the PC1 here, this time being a temporal parietal sort of network here. The auditory verbal learning test was, again, not well predictive across cohorts, regardless of the modality we could pick. And the Fugel-Meyer test did provide a small but noticeable prediction of the intercept for this modality. Finally, if we ask which predictor is best, the answer seems to be that it's all of them, although there's some slight variations across domains. For here, individually, the functional mapping will provide the most a variance explained by itself, although all of the mappings together provided the most variance explained, as you can see. And for the complex ideational material test, we see the same pattern with a strong prediction from the functional mapping and slightly higher when we combine all of them together. For the Hopkins, for the memory domain, we see that once again, all predictors combined is the best, but the best individual one was the lesion behavior map alone. Finally, for the motor domain, again, we see the best prediction from all maps combined, but individually, the structural mapping was the best. So can we use lesion behavior mapping and lesion network mapping to predict post-stroke outcomes? I think the answer is probably yes. We saw that across domains, that we can best predict the 12-month outcome by doing so. As far as the implications of my work, I think from a big picture perspective, we can start using the tools and knowledge and methodologies of cognitive neuroscience to try and move the needle for our patients and improve our predictive abilities as clinical neuropsychologists. And from a more basic perspective, I think that lesion research could benefit from using multiple methods to localize brain functions. So the true nature of a brain behavior relationship probably needs to be triangulated from all three of these modalities, not just any one. I'd like to acknowledge my funding sources and my labs, like Aaron Bowe's lab and Dan Chernell's lab. And here's just some more info about me and where you can find me online and where you can find this paper one day published in Brain, as it was accepted for publication pretty recently.